Ken Landau. Thanks for watching. Let's talk about DVT, deep vein thrombosis, blood clot in the deep veins, typically of the legs, not the arteries, so they're not associated with heart attack or stroke, but they're still responsible for about 100,000 deaths a year, or 275 deaths a day, or one death every 5 or 6 minutes. And if we look at people who die in the hospital, probably 1 in 10 die as a complication of DVT and then a pulmonary embolism when the blood clot breaks loose from the leg and travels into the lung. The Centers for Disease Control suggests we're going to have about 300,000 to 900,000 DVTs this year in the United States. More than 50% of the time they're going to be asymptomatic. And if you have one, you have about a 30 to a 40% chance of having another within 10 years. Now, the overall family of diseases we're talking about is the venous thromboembolism. DVT accounts for part of that. About 2/3 of the VTE, venous thromboembolism, are just simple DVTs, blood clots in the veins. But in 1/3 of the cases, the clot can break off. And when it breaks off, then it travels oftentimes to the lung. That's the rest of the story. That's the pulmonary embolism. That's where we get the mortality and the morbidity. So if you have a pulmonary emboli, the chance of death within 30 days might be as high as 6%, chronic pulmonary hypertension in 3 to 4%, and you have a complication with the DVT in the legs. Ultimately, you might get the post-phlebitic syndrome in about 25 to 50%. Well, it's a common condition. DVTs occur on average in about 1 in 12 people, so your risk over the course of a lifetime is about 8%. However, in the African American community, the risk is about 12%, about a similar number in people who are overweight. Significant number of these DVTs occur because of hospitalization or surgery. But if you have a family history, that increases your risk. If you have a problem with your blood flow because of inactivity, you're sitting too long, or you're confined to a wheelchair, or you have a long airplane travel, or you're paralyzed, then that increases your risk. You have an increased risk if you have a broken bone, a motor vehicle accident, some kind of injury to the bone or the muscle or the vein. Increased risk if you have surgery, especially orthopedic surgery, especially knee or hip replacement surgery, increases the risk dramatically. Or if you're hospitalized, especially in ICU, or if you sit for too long a time period. Long time period is defined as more than 4 hours, especially if you have your legs crossed, or you're confined to a wheelchair, or you're bedridden, or you're in a long-term care facility, or you're paralyzed, or you have active cancer, or you have some other kind of disease. Maybe you have cardiovascular disease, congestive heart failure. Maybe you have central venous line. Maybe you have lung disease. You smoke cigarettes. You're pregnant. Women who are pregnant, who deliver, well, in the 6 weeks after delivery, the risk is markedly elevated. Some people say the risk might extend even to 3 months. Risk is also increased in people who are diabetic, people over age 65, or who have certain autoimmune conditions or chronic infections or family history of clotting disorders, or people who've had a DVT, people who are overweight. So if we look overall at people who are hospitalized, the risk might be anywhere between 10 and 40% that you're going to have DVT. But if you undergo major orthopedic surgery, that risk increases to 40 to 60%. However, if we use routine prophylaxis, routine anticoagulation, we can reduce the risk quite substantially so that it's only going to be about 1%. Now, after a person delivers, we know that the risk for a DVT increases. And as a matter of fact, DVTs are a leading cause of the maternal morbidity and mortality, especially if the person's had a prior VTE, venous thromboembolism, or DVT. Person has had an inherited clotting disorder, older age, maybe had a C-section or is overweight. And even in children, although it's very uncommon in children, it's the second most common cause of preventable harm in children who are hospitalized, second to infections. If a child has a central venous line and has some other kind of a medical ailment, that increases the risk quite dramatically. And certainly there are genetic factors. So if you have a clot that's unprovoked, we don't have any reason for you to have the clot, and it occurs, say, less than age 50, or if you have a strong family history, or if you have a recurrent arterial or venous thromboses, then we might want to check some of the blood abnormalities. We find factor V Leiden or prothrombin gene mutations oftentimes, but they don't tend to really require therapy. So they sort of spook us when it would be better to not test for those. Well, when we talk about risks overall, we talk about provoked or identifiable causes. So that happens in about 25% of the cases. Half of them are soon after hospital discharge. About 30% of the cases associated with cancer, and another 50% of the cases associated with no factor that we can find. Although some of them might have occult cancer, we tend not to go looking for that. Most of the clots, when they occur in the thigh or in the pelvis, not in the calf. They can break off and spread to the lung. If a small piece breaks off, then chances are you survive. If a large piece breaks off, chances are you die, unfortunately. The site of the DVT, or the deep vein thromboses, tends to be the proximal veins, the femoral vein or the popliteal vein. Those are the veins in your thigh or behind your knee. 20-30% of the time it's isolated to a vein in the calf. The veins in the calf don't seem to cause the spread nearly as much as the veins behind the knee and in the thigh. If you have an isolated DVT, the risk of extension and spread is probably only about 15%. We worry about the distal DVT, the DVT in the calf, if it happens to be long, if it happens to involve multiple veins, if you have a history of cancer, if you've previously had a DVT, then we worry about it. Oftentimes, when a person develops a DVT, say symptomatic, you don't have any kind of symptoms that give us a clue, but sometimes the skin might be warm to the touch, or it might be red or discolored. Sometimes there's dilation of the superficial veins, or even pain or tenderness without any good explanation. So sometimes it's misdiagnosed as cellulitis or lymphedema or venous insufficiency or a hematoma or a ruptured Baker's cyst. Diagnosing the pulmonary emboli, that's difficult too. Difficult because the symptom might just be some vague chest discomfort, maybe when you take a deep breath, or you feel lightheaded or faint, or you have shortness of breath without any other explanation, or maybe you cough up some blood, or you increase your heart rate. Some people, unfortunately, develop symptoms similar to those of acute coronary thrombosis, heart attack. So we basically have three underlying factors that we have to consider. We have to consider endothelial dysfunction. The vessel isn't working right. There's some inflammation or something that's causing a clot to form. And then stasis, because we have disordered flow. The blood isn't moving, or the blood is hypercoagulable because of some genetic abnormality. That's what we call Virchow's triad, the vein, the blood, the flow. And we have valves in the veins. And the valves assist with getting the blood back to the heart. Now, of course, the heart pumps the blood out, but once the blood gets down to your foot, what gets the blood back to your heart? Well, it's the movement of your muscles that pushes it, and it's aided by veins that have valves. The femoral vein, within about 2 inches of the inguinal ligament, has about 4 valves on average. The popliteal vein behind the knee has about 2 valves. And unfortunately, behind those valves, when the valves are open, behind them, that's an area where we don't get good blood flow. And because we don't get good blood flow, we have stagnation, decreased oxygenation, increase the hematocrit, increase procoagulant factors, increase a variety of other factors that tends to cause a clot. So in the clot, we have the central white portion where the platelets are, then we have the outer red portion, and then we have the fibrin and the extracellular DNA and the histone and a variety of other substances that surround it. So how do we test for DVT? Well, first we have to think that it might be an issue, because oftentimes people don't even think about the DVTs. So sometimes we think about it when you don't have it, sometimes we don't think about it when you do have it. So we have to keep this foremost in our mind. So we think about the risk factors that I just mentioned. And if a person has some of those risk factors, then we like to consider some sort of a test. Well, the first test in those people who seem to be at relatively low risk might be a D-dimer test. That's a blood test. That has to do with people who are at relatively low risk. On the other hand, if we have high risk, if you have the pain or if you're going through surgery or if there's some other reason to believe that DVT is in your future, then we go right to ultrasound examination. So if a person has a high risk, then when they're seen, they're almost immediately treated with some low molecular weight heparin or some Xarelto or Eliquis, those two specifically. We can do the D-dimer test. If the person has a low probability of having a DVT, then that probably is going to be sufficient if it's negative. But unfortunately, the D-dimer test tends to be positive in so many instances. It's positive if you had recent surgery, you had some bleeding, you were pregnant, you had cancer, you had some sort of trauma or sepsis or chronic kidney disease or a burn, or you're just older. And as a matter of fact, if you're older, we have to adjust what's the normal rate, what's the normal value. We multiply your age by 10. That's what we consider normal if you happen to be over age 50. We do this so that we don't have to evaluate unnecessarily too many people. But if the risk is thought to be higher or the D-dimer test is higher, then we go to an ultrasound examination. And the ultrasound examination is pretty doggone good at examining or detecting the blood clots. Now, there are two acceptable strategies. Since most of the clots that we worry about occur between the groin and the knee, we can just examine that area. But if we do just that area, then we have to come back in a week and redo it to make sure you didn't have a clot in your calf vein that has spread. Or we can just simply, the first time, do everything, do the back of the upper leg and the back of the lower leg all at one time. Now, if you happen to have had a DVT 1 year, and now let's say the next year or the year after, you have some symptoms again where DVT is considered, that makes the diagnosis a lot more difficult because the ultrasound probably is not going to be normal. Venography, where we inject some dye into the vein and take a bunch of x-rays, that sort of is old-fashioned and didn't seem to really be as good as some of our newer tests. For examination of pulmonary emboli, we have we have the ventilation perfusion scans, and we have CAT scans. We have other ways of making the diagnosis. So now we consider anticoagulation. That's the mainstay of therapy. It decreases mortality, decreases the extension of the DVT, decreases the likelihood of recurrence, can decrease the risk of the post-thrombotic syndrome in the leg, and decreases the risk of pulmonary hypertension. So our choices are anticoagulation with heparin or low molecular weight heparin. Those are injections. Warfarin is a pill. We have to test frequently to make sure your INR is between 2 and 3. Or we can use one of the novel oral anticoagulants. Novel oral anticoagulants, or NOACs, are Xarelto and Eliquis, or Pradaxa and Savasa. Or we could use just plain aspirin, but plain aspirin doesn't work very well for the overwhelming majority of people. So the initial treatment nowadays, because it's so simple, is either Eliquis or Xarelto. On the other hand, we could start with the anticoagulation with heparin, low molecular weight heparin or unfractionated heparin, and then either add the DOAC if we're going to add the Pradaxa or the Savasa. We could have started off with just plain Xarelto or Eliquis, as I mentioned. Or we can start with the heparin and then proceed to the warfarin. Well, the choice seems to have to do with the safety and the efficacy, whether you have liver disease or kidney disease, whether you're taking other kinds of medicines, what's the availability, what's the familiarity with the doctor and the medicine, what's the preference that you have, what's the cost of the medicines. So the NOACs or the DOACs, they seem to be the first line in uncomplicated individuals. However, if the person's pregnant or has a creatinine clearance kidney function that's impaired, liver function that's impaired, we have a mechanical heart valve, or you're taking other medicines that interact with some of the enzymes necessary to metabolize the NOACs, then maybe we don't choose them. For those people, maybe the low molecular weight heparin would be the most appropriate initial therapy, with then transition to the warfarin or the Coumadin. How long should we continue therapy? It all depends on the risk factors, all depends on what else is wrong, all depends on why you had the clot in the first place. But typically it's between 6 and 3 months and 6 months or longer. Now, what do we do if a person's pregnant? We can't use warfarin if a person's pregnant because it's embryotoxic. We don't really have great experience with the NOACs at this time, so low molecular weight heparin seems to be the best choice. Now, if a person has cancer, some people treat prophylactically in individuals with cancer, other people don't. The choice would be either Xarelto or Eliquis, or low molecular weight heparin probably would be sufficient. People have gastric cancer, GI cancer, colon cancer, then maybe low molecular weight heparin might be a better choice. After we begin a course of low molecular weight heparin, then in some people maybe we could transition to the NOACs. Well, what about orthopedic surgery? You're going to have your knee replaced, you're going to have your hip replaced. Well, unfortunately, you have very high risk of developing a DVT, so what we do is we begin some therapy. We begin therapy as soon as possible after the surgery. The anticoagulation tends to last between 10 and 35 days. Now we can start with Xarelto for the first 5 days and then continue for 9 days after knee replacement, or 30 days after hip replacement. Or we can use Xarelto for 5 days and then transition to aspirin alone. That was the result of a recent report in the New England Journal of Medicine. Whether that's going to become standard or not remains to be seen. Well, what about the idea of recurrence? Recurrence is relatively frequent with DVT. So once a person develops a DVT, we always have to be on guard. And if a person develops a DVT again while they're on therapy, maybe we were giving them a suboptimal dose. Maybe it was an incorrect dose. Maybe the patient wasn't really taking the medicine as we prescribed. Or maybe there was an emergence of a different kind of a risk factor. Maybe the person now has a tumor, has cancer. And then we have to consider the risk of bleeding. The blood thinners will make you bleed. Well, some people are at higher risk of bleeding. Maybe if you have previous bleeding, if you're over age 65, you have metastatic cancer, you have chronic liver or kidney failure, you have a decreased platelet, maybe you have diabetes, or you previously had a stroke, you have some comorbid disease, you had recent surgery, you fall, you misuse alcohol or other drugs, that puts the risk of bleeding increase. So that would suggest that maybe we don't want to use the anticoagulants. Well, what about clot busters? Injectable clot busters. Well, they can increase the risk of bleeding complications and increase the risk of hemorrhage, so we don't use them unless you've had a massive DVT and pulmonary emboli. What about the risk of surgically removing the DVT? Doesn't seem to be really appropriate in the overwhelming majority of cases. There's an inferior vena cava filter that can be used. Doesn't seem to increase the survival in patients, but can prevent pulmonary emboli. It's used when you can't undertake the anticoagulation, or if it's contraindicated because you've recently bled or you're going to have surgery. And then there's prevention. What do you do to prevent a DVT? Will you be aware of those those factors that tend to be associated with the condition? You get up and move about. If you're on a long trip, you exercise the muscles of your calf and your thigh, you stretch. You can do that right while you're sitting down. The idea about mechanical compression, those stockings, well, in 2016, the American College of Chest Physicians said they can help prevent swelling and discomfort, but they don't prevent the recurrences. Then we have the post-thrombotic syndrome. The post-thrombotic syndrome is very common. It occurs somewhere between 25 and 50% of the time after a DVT. It's due to damage in the valves that allows the blood to pool around the leg. That leads to some edema and swelling, especially around the ankles. Leads to some dilation of the superficial blood vessels and brownish pigmentation around the lower leg between the knee and the ankle. Leads to some venous eczema, some aching and pain and crampiness and heaviness and itching and tingling of the skin. Can lead to some increased thickness of the skin, and oftentimes to some ulceration that occurs especially around the ankle. Seems to be associated with fewer symptoms while you're lying down, more symptoms while you're up and about. The compression stockings, especially if they're 30 to 40 millimeters of compression at the ankle, well, they can help prevent some of the ulceration, but they're extraordinarily difficult to get on, and they're not very frequently used or not used appropriately. So anyway, that's the story of DVT, or deep vein thrombosis, a clot in the deep veins of the leg, typically in the area from the groin to the knee. Hopefully people can avoid them if you're going to have surgery by appropriate prophylactic therapy, especially if you're going to have orthopedic surgery, or if you're confined to bed. If you're taking a long air travel, well, get up and walk around, and if you can't get up and walk around, use the muscles of your leg and your hip, push against the floor, lift your toes, push down on your heels, lift your heels. And for some people, it might be appropriate to take prophylactic therapy or treatment. Treatment nowadays seems to be Eliquis and Xarelto, or Pradaxa or Savasa. Those are more commonly used now than warfarin. However, there are some instances where warfarin is still preferred. Unfortunately, the newer drugs are much more expensive, but they're more convenient. You don't have to get repeat blood tests. So anyway, thanks for watching. If you enjoyed the show, please tell a friend. Consider subscribing so you'll be notified when we post new videos. And as always, I appreciate your interest. I'm Dr. Ken Landau.